My name's Bill Evans. I'm from the Department of Economics at the University of Notre Dame, and thanks for joining our presentation about our new NBER working paper with my colleague Chris Cronin, also from Notre Dame. In this talk, we're going to provide some basic facts about the COVID-19 crisis in nursing homes. And then we're going to outline the role of nursing home quality in combating the pandemic. And one thing I'll say at the beginning, there's no way around that these numbers are incredibly sad. Just the level of loss that's occurred in nursing homes. The COVID-19 virus is particularly risky for two groups, the elderly and people with particular conditions. And these sets of risk factors are highly prevalent in nursing homes. So these are incredibly vulnerable institutions, which it is important to sort of think about how we're going to deal with this moving forward. We're going to use two sources of data on mortality in nursing homes from COVID. One are information from state web pages. All states have a dashboard that has a running count of how COVID is impacting their states. Not all states report this information, but the information that's reported is fairly complete. We're going to supplement this with information from a new data source that's put together by the Centers for Medicare and Medicaid that has weekly data on COVID cases, mortality, et cetera, for all nursing homes in the country. This data was started to be released on May 24th, and it comes out weekly now. Unfortunately, this data set tends to undercount COVID mortality within nursing homes for a particular reason. The first week that the data was released, they allowed nursing homes to report either the cumulative number of deaths up to that point for the year or the deaths for the week ending May 24th. And a lot of nursing homes, especially in some high-risk states, chose the second. This means, however, that the deaths between, say, the end of May and today appear to be fairly accurate, but just in terms of matching these two things up, the CMS data is going to understate mortality some. The first fact I want to point out is that the COVID situation in nursing homes has been a disaster. As of September 13th, 2020, there have been about 192,000 COVID deaths for the country as a whole, and 56,000 of these have been in nursing homes, which is about 39% of all COVID deaths. So this is a large part of the problem. If you take a look at COVID deaths rates, which are deaths per 100,000, for the nation as a whole, as of September 13th, that number was about 59 per 100,000. If we were to take a look at the number for non-nursing homes, that number falls to 36. A group of people that's comparable to those in nursing homes are the non-nursing home patients age 65 and above. Their death rate is 208, but the nursing home death rate is about 5,500 per 100,000. About 5% of nursing home patients have died since the beginning of the year because of COVID alone. This is 150 times the non-nursing home rate, so it's a staggering number. The second fact is that death rates in nursing homes are tied closely to the underlying risk in the general local population. In this graph, we use data from the CMS reports and construct death rates for nursing home residents. That's on the vertical axis, and then on the horizontal axis, we take a look at state non-nursing home death rates per 100,000 and just fit a line through these points. These are strongly correlated with a correlation coefficient of about 0.8. So it's no surprise that in areas that have had the biggest risk, Massachusetts, New Jersey, Connecticut, they've also had the largest nursing home death rates as well. Unfortunately, the virus is not the only risk that people in nursing homes face. There's tremendous excess mortality not associated with the virus among the elderly and particularly Alzheimer's patients. This is a graph of deaths by week for those 65 and older. The dotted gray line at the bottom is the average deaths per week in 2018 and 19. It represents a baseline. The black line are all deaths by week in 2020, and clearly there's a massive increase around April and March when COVID was really hitting quite hard. But the gray line here are all deaths in 2020 minus COVID mortality, and these are excess deaths that are attributable to things like heart attacks or violence or just depression that's occurring. And notice that about a third of the total increase in mortality is due to non-COVID reasons this year. So among people 65 and older, there seems to be a lot of mortality not attributable to the disease itself, but rather to the pandemic in general. These numbers are particularly stark for Alzheimer's patients. As of the end of September, there were about 30,000 excess deaths estimated by the Center for Disease Control occurring among Alzheimer's patients. Only 6,900 of these deaths actually had a diagnosis of COVID. Almost 23,000 of these excess deaths are occurring for people without a COVID diagnosis. And a lot of this is just the disruption of their lives that's occurred has been pretty traumatic for Alzheimer's patients. The final fact is that the crisis is heavily concentrated in a few nursing homes, but the problem is not insurmountable. The top 5% nursing homes, in terms of raw mortality, is responsible for about 40% of all mortality in nursing homes among COVID patients. And fully 58% of nursing homes have had no COVID deaths. This number is actually 31% in states really hard hit in nursing homes, such as New Jersey, Massachusetts, Connecticut, and New York. So a big research agenda moving forward has to be, what are the homes that are preventing deaths doing right? And how can we use this information moving forward? The research question that we focus on in this paper is a relatively simple one. If you had to find a nursing home for a loved one right now, what variables would you focus on? What objective criteria could you use to help you select where your loved one should go? And the one thing we want to point out through all this research is that COVID death rates are tied closely to nursing home quality. The Centers for Medicare and Medicaid have a 5-star nursing home ranking where more stars is better. These rankings have 3 components based on inspections, staffing levels, and quality metrics such as falls and bed sores. The inspections component of the ranking is thought to be less manipulable by the nursing home. So we're going to focus on that measurement in the paper where we present results from all the different quality metrics. And what we're going to do is estimate a statistical model that tries to explain the differences in COVID-19 death counts across nursing homes, controlling for a variety of factors, such as the profit status of the nursing home, how big it is, the underlying risk level that the nursing home has in the county in which it's situated. Plus, we're going to control for, just differences across states because of things like regulatory environments. In the next couple of graphs, what I'm going to do is report the coefficients as we move from a 1 to a 5-star ranking. And the results can be roughly interpreted as a percentage difference in mortality attributable from moving from a low to a high quality nursing home. So in this graph, I report the percentage change in mortality as you go from a 1 to a 2, 3, 4, and 5-star nursing home. The gray bar represents the estimated effect, and the small darker gray line represents the 95% confidence interval. And 5-star nursing homes have 24% lower COVID mortality than a 1-star nursing home. So the effect of quality is fairly massive in this particular case. How do high quality nursing homes reduce deaths? Well, we know what they don't do. The results seem to indicate that they don't prevent the disease from entering the nursing home. Quality is not predictive of whether you have any resident or staff cases. So what nursing homes seem to be able to do, high quality nursing home, is prevent the spread of the disease conditional on a case. So how do they end up doing that? Well, our results suggest that they tend to have lower staff shortages and lower PPE outages. And this explains a large fraction of the quality difference between them. They just seem to be better run institutions to deal with the things necessary in order to handle the pandemic within the nursing home. The problem, however, is that quality nursing homes appear to generate greater excess mortality. Nursing home residents have experienced a tremendous amount of extreme isolation. Visitors are prevented from entering, group activities are prevented, group meals have been discontinued. And so as a result, there's been a lot of dislocation within nursing homes, especially for particular patients like Alzheimer's patients. So in our statistical model, we're going to run exactly the same model that we did before, but what we're going to do is change the outcome from COVID-19 deaths to non-COVID mortality and take a look at what's happening to mortality along these other dimensions. This is a graph that takes a look at the effect of moving from a low to a high quality nursing home in on non-COVID mortality. And unfortunately, in 4- and 5-star nursing homes, they tend to have about 9% more mortality for these non-COVID causes than a lower quality nursing home. Now, non-COVID deaths are more prevalent than COVID deaths. So when we take a look at the effect of quality on total mortality in a nursing home, there's no effect whatsoever. Now, we've examined some of the heterogeneity in this across different types of nursing homes. And the one that we find to be incredibly predictive is that we split the sample into nursing homes in counties that are above and below the median COVID case rates. And so these are essentially high and lower risk areas. The high quality nursing homes still reduce COVID deaths in these low quality areas, but the increase in non-COVID deaths in low risk areas is incredibly large. And so this kind of makes sense. All nursing homes isolate patients. In low risk areas, there's very little benefit on the COVID side of this isolation just because they don't face as much risk. However, because of the isolation, they're experiencing most of the cost as a result. So in this graph, we take a look at the percentage change in non-COVID deaths moving from low to high quality nursing homes in those nursing homes that have below the median risk. And notice that the effect on mortality on these non-COVID deaths is monotonic in quality. And in the 5-star nursing homes, they're experiencing 20% higher non-COVID mortality. If we take a look at the percentage change in all deaths in these nursing homes in below median risk areas, the effect again is monotonic in quality, and there's a 15% increase in mortality in these nursing homes that have the higher quality. So the areas that have experienced the least COVID risk, which have also isolated patients, have experienced a lot of non-COVID mortality as a result. So the efforts to protect patients were successful at reducing COVID mortality risk in high quality homes, but it did come at a cost, and that it increased isolation and it increased excess mortality. This was heavily concentrated in homes with low COVID risk, which suggests that maybe we need a more nuanced policy in terms of the way in which we deal with residents in these nursing homes. And there's a current CMS circular that came out maybe a month ago that starts to outline how to allow visits in areas with little or no risk, visits outside, visits within the hospital or within the nursing home, to try to deal with this problem of social isolation that's occurring within nursing homes. So that's a brief outline of our research. If you Google William Evans, you can easily find my email address if you have any other questions about our research. And thanks for taking a look at this video. Have a good day.